Okay. Okay. So good afternoon, everybody. Thank you for joining, despite all your time differences from where are you now in the world. This is a webinar from the joint webinar series that we organized together with the European Academy of Neurology and with the European Reference for Neuromuscular Disorders. And the topic of today's webinar is clinical evaluation of dystonia and will be presented by Kailash Bhatia. I will give you just some information, general information on the webinar. So we will have a presentation of around 35 to 40 minutes. And then at the end, we will have a questions and answers session. So please, if you have any questions, general questions, you can write them in the chat box. And for any content-related questions, please write them in the Q&A box, which you can find in the lower toolbar on the left side. So our target audience for these webinars are neurologists, residents, pediatric neurologists, and geneticists. As well as other paramedical personnel involved in patient care. We are recording this webinar, so we will put the recorded version on our website, which you can find here, the link, at latest 2 weeks after today. And at the same website, you can find further useful knowledge for the disease group dystonia. At the end of the webinar, your browser will automatically open a post-webinar survey. So it would be great if you can fill it out. It would take just 2 to 3 minutes because we receive very valuable feedback from those surveys. So we can always improve and improve our webinars. So let me tell you some words on the European reference networks, since I would say the attendees, the group of attendees today and also on the other webinars until now are a very heterogeneous group. So coming not only from Europe, but also from Asia and US and Canada and so on. So not everybody is familiar with the European reference networks. The European reference networks are groups of healthcare providers, of hospitals, which have a special expertise on a disease group that is covered in that network. And these networks were created by the European Commission so that the discussion and collaboration between experts is facilitated and intensified so that that knowledge on rare diseases can be concentrated and the patients can be better and more efficiently cured or helped. So you can see the dark blue countries are those where we have a full member hospitals, and the ones with light blue are the countries with affiliated partners. And there are 24 European reference networks on different kinds of diseases, and European reference network for rare neurological diseases. So we are coordinating that, and this is ERN-RND. If I mention it afterwards, then you will recall the abbreviation. Okay, so I'm today very honored to welcome our speaker, Kailash Bhatia, who you most probably know, who is professor of clinical neurology in the Department of Clinical and Movement Neuroscience at the Institute of Neurology at the UCL in London. And he's fellow of the Royal College of Physicians and American Academy of Neurology. And his main research interest is in pathophysiology of movement disorders like dystonia, Parkinson's disease, and the typical Parkinsonian syndromes, which he's approaching with several methods like clinical, electrophysiological, or genetic methods. He's a current and founding editor-in-chief of the Movement Disorders Clinical Practice Journal and former associate editor of the Movement Disorder Journal. He's delegate and full individual member of the European Academy of Neurology, so our partner for these webinars. And he has recently started a term for 2 years as secretary-elect of the European section of Movement Disorder Society in order to continue the close collaboration in the education field with the EAN. And Kailash Bhatia has currently over 620 peer-reviewed publications. He has worked also on several books, and including the Marsden Book of Movement Disorders, for which he has received the British Medical Association Award in 2013 as Best Book in Neuroscience. And he has a leadership role in the International Parkinson's Disease and Movement Disorder Society, and has served on various committees of MDS, including their Central Science Program Committee and the International Executive Committee. So as a professor, he has trained many fellows and students in his career until now, and I am very glad and that Kailash is today with us and that he is also sharing his knowledge today. So thank you for joining and for accepting this invitation, Kailash. And now I will stop sharing my screen so that you can start your presentation.
Thank you very much, Sanya. And let me just see if this will work. Webinar is a interesting way to do this. Obviously, I can't see whom I'm speaking to. I know there are people out there, hopefully. Is there a way to know who is the audience, Sanya? Is there?
Yes, we will know after the webinar, but at the moment, what I can say is that we have 73 attendees.
Okay, very good. So I'm going to talk about the clinical evaluation of dystonia, just to give you an update about this. As you know, there is a new classification of dystonia, a consensus statement, now a few years old, but still quite valid. And in this, with regard the dystonia, that's what we will start with, the definition. All of you recognize that dystonia is characterized by these abnormal postures due to the sustained and intermittent muscle contractions. But there are a couple of new things in the new classification. A lot of us recognize that many patients with dystonia have tremor, and this in fact is now an integral part of the dystonia definition. And we also recognize that dystonia is often initiated or worsened by voluntary action, and often there is overflow. So all of these components are now admitted within the classification, within the definition of dystonia. The other thing which I think is particular for dystonia, which we need to recognize, as I said, apart from tremor, like this example in this lady who has clear torticollis and tremor, is a sensory gest. So sensory gest is a peculiarity in dystonia, and it's not seen in other dyskinetic movement disorders. So if this is present, you know that you may be dealing with a patient with dystonia. The other feature often is the task specificity, as shown in this patient here, who has a dystonic writer's cramp. So first question I think you're faced with is, when you see a patient with an abnormal posture, is it really dystonia? Not all abnormal postures are dystonia. So we have a lot of what we call pseudo-dystonias or imitators of dystonia. So for example, somebody may have a head tilt due to a vestibular problem or a trochlear nerve problem. You may have a spine which is bent with comptocomia or scoliosis. So you got to be aware of these other causes, which may be muscular or skeletal, which lead to a fixed posture quite often, and that's not dystonia. So this lady, for example, has fixed head tilt following a neck injury. So not everything you see with an abnormal posture is dystonia, and we have a list in this particular paper listing the pseudodystonias which you should be aware of. And when you're seeing your patient, we have divided this into axis 1 and 2, and the axis 1 deals with the clinical characteristics. It's very important when you're seeing your patient with dystonia to know what is the age of onset. Is it in infancy, childhood, adolescence, early adulthood, late adulthood? And the second important thing is, what is the body distribution? These two facts are very important for us. And the reason for this is that over time, we have learned a clinical association when we are trying to divide dystonia into primary or idiopathic causes or secondary heterodegenerative causes or symptomatic causes, that age of onset and body distribution is very important, as you will see. So with regard body distribution, is it focal, just one part like somebody with torticollis? Is it segmental, or is it generalized? And then another thing in the clinical characteristics, and this is new, is regard associated features. Of course, you're looking at the temporal pattern as well. Is it action induced? Is it paroxysmal? Are they diurnal fluctuation? But this here is a new thing with regard the consensus statement. Is the patient you have seeing with dystonia have isolated dystonia, or is the dystonia combined with other either neurological or systemic manifestations? So for instance, you would spend your time in your patient with dystonia. You've seen that he's got dystonia, but you're going to spend your time looking at, are there other features? Is there myoclonus, for example? Is there Parkinsonism? Does he have peripheral neuropathy, etc.? Because that will help you deal with the etiology. So number of etiologies of dystonia, and we have divided this in axis 2 as either due to nervous system pathology, evidence of degeneration or structural causes, is it inherited, acquired, idiopathic. Number of dystonia genes have been described. This is just one list over here, and this list is by no means complete, because the numbers are going up even up to DYT26 and so on. So for a newcomer in the field, this can become quite daunting. There are a number of heterodegenerative causes of dystonia, Wilson's disease, GM1, GM2, a number of different disorders. So how does one approach this? Because if you're just seeing your patient with dystonia, what are the clinical characteristics that you should follow so that you can come to some understanding about the underlying etiology, which of course then determines what the prognosis and the treatments might be. So in this regard, since that paper of the consensus statement has been devised, there have been some other papers giving you a sort of a review of assessment of patients with isolated or combined dystonia. And this is a very nice one from Victor Fung. So if you just go back for a minute, we think about, and this is from the old classification where we used to talk about idiopathic versus secondary, but this is still valuable. I told you that the age of onset and the distribution is very important. So we have recognized over the years that the young age of onset usually starts in the limbs, tends to spread, as in this patient, and can become generalized. So this gentleman has DYT1 dystonia, and he has isolated dystonia. Similarly, adult onset focal dystonia, as you can see over here, this lady with cervical dystonia, which is torticollis, and apart from dystonia, she doesn't have anything else. The onset was, excuse me, in a later age, at the age of 50 or 60, unlike this gentleman, who had a very early age of onset. So we had been able to define that the later onset dystonias are generally affecting the neck, and they come in their 50s or 60s, more common in women, while the younger onset starts in the limbs for idiopathic dystonia. So that leads us to patterns. So here we have got a table, which I don't know whether you can see very well, but it divides the patients into isolated and combined dystonias. But even within isolated dystonia, there are red flags for the subsequent development of combined dystonia or a neurodegenerative disease. So for example, if you get cranial dystonia in a young adult or a child, that's not right, because we know that the craniocervical dystonia comes later in life, comes in adults, or the other way around. An adult develops lower limb dystonia. That is not right distribution and the age of onset. And here, even though it is isolated dystonia, you have to be careful because this patient may have another cause rather than it being a idiopathic type of primary dystonia. So that's very important with this regard. So it's about pattern recognition. Here is somebody with isolated young onset limb dystonia which became generalized. That's fine. That's okay for primary dystonia. Here is somebody with late onset craniocervical dystonia, age of onset 55, she's woman. That's fine. But here is somebody with young onset oromandibular dystonia. And you say, even though this is isolated dystonia, at this stage, this distribution and age of onset is not correct. And hence, this is somebody you would be cautious in, you would investigate, and this lady turned out to have an NBIA with iron deposition in the brain and very characteristic eye of the tiger, which is due to the PCAN gene mutations. So the reason why you were careful about this patient, not calling her isolated dystonia and not investigating her, is because the age of onset and the distribution was not correct for that. So there are a number of red flags against the diagnosis of idiopathic dystonia. The important one is unusual pattern of clinical manifestation with regard age of onset and distribution. That's what I've been just talking to you about. Sudden onset of symptoms, rapid progression, exposure to drugs, presence of other neurological or systemic signs, a lot of bulbar involvement. So primary dystonia usually does not affect the bulb. So these people will have a lot of bulbar involvement or a lot of tongue protrusion and dysphagia. This is a bit unusual for idiopathic dystonia. This is seen more in NBIAs or neuroacanthocytosis, etc. So you would think you would be careful about a secondary cause. Occasionally, you can have somebody with orofacial dystonia, which is isolated, particularly in older age of onset. But in the young ones, that should not happen. Hemidystonia, fixed dystonia are obviously red flags for primary dystonia. And there are, as I told you, a number of genes causing dystonia. So how do we go about that in this day and age? And again, here we are using the new definitions which I just told you about. Is the dystonia isolated or is it combined? And within that, if it is isolated, there are certain genes to consider if it is generalized, and there are certain genes to consider if it is focal or segmental. And there can be a bit of overlap in this, but in this particular paper, in the ones which are bold, are the more important ones, and then the smaller print, which are the less important ones. So for example, here in the generalized form, DYT1 with isolated dystonia would be an important cause, but there are others as well. And then you can have your combined dystonias where you think about additional signs. So for example, for myoclonus dystonia, there may be certain genes. For dystonia Parkinsonism, there will be certain genes, and we can accordingly define the syndrome and then think about the etiological causes, particularly the genetic causes underlying that particular syndrome. So just a few words about some of the isolated generalized young onset dystonias. This is somebody with a DYT1 gene. You can see she's very young. She's got limb dystonia, lower limb dystonia, which can go on to become generalized. This is autosomal dominant disorder, usually spares the craniocervical region. It's important to recognize this because many of these people, if they don't have a good enough response to oral drug treatment such as anticholinergics, can respond dramatically well to GPI, DBS stimulation. And this is a GAG mutation, more common in the Ashkenazi Jewish population. So that's DYT1. Another cause of early onset isolated dystonia is DYT6 or TAP1 gene mutations. I told you that orofacial dystonia is uncommon, but in TAP1, the lingual area, speech is very early involved. And this lady was unusual that she had a lot of oromandibular involvement, but she had isolated dystonia and nothing else. And she was found to have a DYT6 mutation. So if you see the table over here, these people have young onset. A lot of them have laryngeal onset or oromandibular facial dystonia. Some of them have a segmental onset involving also the upper limbs. And if you compare this to DYT1, DYT1 starts over here and spreads upwards, usually spreading the craniocervical region, while DYT6 starts there and may spread downwards into the lower limbs. There are some other recently described or more recently described craniocervical isolated dystonia genes. One of them is CIS1, although other people have not confirmed this. But the two important ones which you might wish to remember is mutations in ANO3 and mutations in GNAL. Now, ANO3 causes craniocervical dystonia, and this is the first, one of the first genes of isolated dystonia where an ion channel was implicated. I will come back to that in a minute. So GNAL encodes the alpha subunit of the triheteromic G protein, which is involved in dopamine D1 signaling. This is a rare cause of cervical dystonia, but may be important from the pathophysiology point of view. ANO3 also causes craniocervical dystonia, and these are people usually in their 30s or 40s, so a little bit earlier in onset than the classic sporadic craniocervical dystonia. And many of these people have tremor in addition to the dystonia. So you'll see some of them here from this particular paper. This is a gentleman with cervical dystonia with a head tremor, which you know happens quite often in cervical dystonia. He also has a little bit of limb tremor. This is a lady with, again, with a tremulous cervical dystonia. Here's another family, and this lady had involvement of her larynx, but then she developed a rather jerky dystonia, which resembled myoclonus dystonia with these retrocolic quite quick jerks. And this gentleman presented mainly with tremor, and then later on developed a mild dystonia of his neck. So ANO3 can have a craniocervical presentation with a lot of tremor, but it can also have myoclonus dystonia type of phenotype, but later in onset than the classic myoclonus dystonia. So those genes which I talked to you about so far were all autosomal dominant. So we talked about DYT1, we talked about DYT6, we talked a little bit about ANO3 and GNAL. Now we are talking about some new autosomal recessive isolated dystonia genes. So one of them is hypocalcin, HPCA. This is also known as DYT2. And this particular family, there were 3 SIBs from a consanguineous parents who all, as you can see, had craniocervical segmental dystonia as their presenting and main feature. Other people have now confirmed this gene in other families, and some of them can have mild cognitive abnormality and mild eye movement disorder. So it may not be always just isolated dystonia. Some other features can be present in some of these patients. So hypocalcin again has a role in voltage-gated dependent calcium channel. So it's another gene apart from ANO3, which I just told you about, where there is involvement of ion channel. So we've covered this part here. We talked about isolated dystonia genes. We talked about some of the ones which cause generalized dystonia. We talked a little bit about some of the ones which call focal segmental dystonia. We are now moving to some of the combined dystonia disorders, for example, those with myoclonus and Parkinsonism. So the classic form of myoclonus dystonia is shown here in this lady, where she has very typical lightning jerks, so very quick jerks. Now, craniocervical dystonia can be trembly, so it can sometimes be a bit of a confusion for people where to consider the epsilon sarcoglycan gene, which is the cause of myoclonus dystonia, also called DYT11. So in contrast to the classic craniocervical tremulous dystonia, the jerks here are much, much quicker. And these patients are much younger in onset. So they usually start in the first or second decade compared to the classic craniocervical dystonia. So as we've shown in this paper, the patients who are positive for the epsilon sarcoglycan gene, the age of onset was very early. Most of them, when they are in adulthood, have a very particular distribution of the jerks. It involves the neck and the upper limbs mainly. As children, epsilon sarcoglycan can actually cause some involvement of the legs, but interestingly enough, the leg dystonia clears up, and then they are left with the myoclonus affecting and the dystonia affecting their arms and the neck. They have a very good response to alcohol in most of these patients, and there is an autosomal dominant family history. So it's a very particular phenotype which the epsilon sarcoglycan patients have. There are some other rarer genes causing myoclonus dystonia. This is one of them, KCTD17. This is a potassium channel tetramization domain gene. It causes abnormalities in the ER and has ER-dependent calcium signaling. Again, something to do with calcium signaling here in this particular disorder. So if you were thinking about the myoclonus dystonia genes, apart from the classic form, the DYT11 related to the epsilon sarcoglycan, which a video I showed you, NO3, we saw a patient of that, KCTD, and sometimes also DYT1 can be rather jerky. There are some others described, but these are the main ones for you to remember. Now we move to dystonia and Parkinsonism. And again, there are a number of causes of this. You have all seen young onset Parkinson's can sometimes have dystonia. Patients with MSA can have antrocholis. Dopa-responsive dystonia can have Parkinsonism. So number of causes, rapid onset dystonia, Parkinsonism, a number of recessive disorders, which we used to call pallidopyramidal syndromes, because many of them also had some pyramidal involvement. So a number of the brain iron accumulation disorders come into this context, Wilson's disease. So a huge number of causes of dystonia, Parkinsonism, and you got to apply the etiology depending on the age of onset and the presentation. So what you have to do are syndromic associations. You combine, in the people who have the combined dystonia, you combine the main findings and you think about the etiologies accordingly. So if you get, for example, dystonia with a lot of bulbar involvement, a lot of bulbar and oromandibular involvement, as in this particular child, then drugs such as neuroleptics, neuroacanthocytosis, brain iron accumulation disorders, Lesch9, these become more relevant. If you have dystonia and peripheral neuropathy, neuroacanthocytosis, metachromatic leukodystrophy, these become more relevant. I showed you we have so many different causes of dystonia, and that's why it's so important to narrow down the differential by making the syndrome and then thinking about the main etiologies which may cause that particular syndrome. Dystonia with retinitis pigmentosa, dystonia with progressive dementia, dystonia with supranuclear gaze palsy, for example, vertical gaze palsy, then you may think about Niemann-Pick type C. If it is an apraxic gaze palsy, you may think about ataxia telangiectasia, other forms of ATM type of disorders, aprotaxin 1, senataxin, etc., and very rarely Huntington's disease. So it's very important for you to make these syndromes and then think about the underlying etiology. Dystonia with deafness, mitochondrial disease becomes important. There are different forms of mitochondrial disease. It may be autosomal dominant, it may be mitochondrial and nuclear mitochondrial genes which are autosomal dominant, for example. autosomal recessive, and so on. So you're thinking about this. One of these here is a rare disorder called Woodhouse-Sakati syndrome, which is very clear because these patients have dystonia, diabetes, hypogonadism, and they can get alopecia. So you can recognize these people quite easily when you see them with alopecia, with a lot of dystonia, deafness, diabetes. So you can pick up patients from the syndrome you're seeing quite often. You can recognize it. So dystonia with anarthria, there's a lot of speech involvement I want to particularly mention. Again, I told you that with the bulbar involvement, number of disorders, a brain iron accumulation, there's a rare condition called HABC, where there is a atrophy of the basal ganglia and cerebellum, inborn errors of metabolism, and brain MRI here is very crucial. But there's one particular condition which has become, we've been aware of recently, and which is an important cause of childhood onset dystonia. And this is related to the KMT2B gene mutations. So this is work from Manju Kurian, and these people are quite remarkable because you can identify them. So they have childhood onset dystonia as seen in this young man, and very quickly many of them go on to develop speech and bulbar problems. Usually their swallowing is affected, but their speech is very affected. So this one has learned to communicate by hand skills because he has lost his speech. They have microcephaly. They usually have a short stature, and they respond well to DBS. So they apparently also have some facial dysmorphism, which is quite characteristic, with this facial elongation, a broad nasal base, and a bulbous nasal tip with this long sort of nose with a bulbous tip. So if you get somebody with very young onset childhood dystonia with a lot of speech involvement, sometimes leading to complete anarthria with relatively preserved cognition and this particular facial expression, then you are thinking about KMT2B. In this particular paper, over 30 cases were described. Normally, when we have a new gene, you have 1 or 2 or 3 or 4 cases described in the paper. So this seems to be a very important cause of early onset, childhood onset, generalized dystonia with a lot of speech involvement. So what does KMT2B do? It's ubiquitously expressed in the brain. It encodes a histone lysine methyltransferase, and the mutations are probably leading to a haploinsufficiency mechanism. The dysregulation of the protein interestingly leads to a reduced level of TAP1 and torsion1 in cultured fibroblasts. So there's a sort of a link between this and DYT6 and DYT1. Another disorder which I think we shouldn't miss and is important is shown in this particular family. So this is a young man who presented with gait dystonia. So when he walked, his foot would turn in on the left-hand side, as you saw here. And apart from this, he had nothing else. And he felt that his dystonia was worse towards the evenings. When we asked him about the family history, he said, yes, my father is seen in the same hospital and has cerebral palsy. And this father was supposed to have a asymmetric cerebral palsy causing him a hemiplegic cerebral palsy. But when we actually examined him, he had more of dystonia rather than cerebral palsy. And the grandfather was said to have Parkinson's disease with tremor. Now, the grandfather had an abnormal DAT scan, while these two gentlemen had a normal DAT scan. So, and all three of them had the same GTP1 cyclohydrolase mutation, which causes dopa-responsive dystonia. And all three of them responded quite dramatically to levodopa. Here's the young man with the foot dystonia, which is better, not completely gone, but definitely better. And here's the cerebral palsy individual who again completely recovered his cerebral palsy with levodopa. As I mentioned to you, the DAT scan in the grandfather was abnormal, while the son and the father had a normal DAT scan. And we found some other families where the proband or the index case who had dystonia had a normal DAT scan, while the father or the grandfather or grandparent had a abnormal DAT scan. And that led us to wonder whether GTP1 cyclohydrolase is a risk factor for developing later onset Parkinson's, and that indeed turned out to be the case in this particular paper. So the take-home message for you, however, is that dopa-responsive dystonia can present in many ways. The classic phenotype, as shown in that young man, was the Sagawa's form with diurnal fluctuation, with exercise-induced foot dystonia in some patients, but also cerebral palsy. So it's very important, therefore, to treat all young children with cerebral palsy, so-called cerebral palsy, particularly if there is a family history. And the later onset can also present with Parkinson's disease. So do not forget dopa-responsive dystonia, because it is a treatable disorder. Just a couple of words about, so what is the point of all these dystonia genes and so on? How are they doing anything for us? Are they helping us? And it's becoming very clear that for the first time now, we have some information about the pathophysiological mechanisms coming out from these dystonia genes. And it seems that many of them have shared mechanisms or network pathways of genes in dystonia, which may have co-expression, co-localization, or a physical interaction of proteins coded by these various genes. And you can broadly summarize the shared mechanism pathways into three. So calcium homeostasis, HPCA, and so on, all of these had, I mentioned to you, had something to do with calcium signaling. Neurodevelopmental defects such as the DYT1, the DYT6, and so on. And then the dopaminergic system, such as in dopa-responsive dystonia or other genes in the dopamine synthesis pathway. The fundamental thing at the brain or the spinal cord or brainstem level is a loss of inhibition and abnormality in sensory motor plasticity. So that's all I'm going to say a little bit about the pathophysiology. Now I come to the practical issue about the approach and investigations in dystonia. So firstly, make the syndrome. Is it isolated or combined? What is the temporal course? Define the syndrome. Very important. When you define the syndrome, then you can ask for tests, specific tests, whether they be genetic tests. If you're thinking about dopa-responsive dystonia, CSF analysis, TERNs, dopamine and serotonin metabolites. If you have combined dystonia and you're thinking about some of the lysosomal pathway defects, metabolic defects, and skin or tissues accordingly. So you need to do that diagnostic workup. In the routine, very important to, if you're feeling that this is not fitting in with your regular cases of dystonia, at least an MRI and copper and ceruloplasmin. So this is my own suggestion. If the dystonia is isolated, if it is young in onset, DYT1, especially if it is an Ashkenazi Jewish. If it's a young adult with isolated dystonia, particularly if there is laryngeal involvement, then DYT6. In some rare cases, TUP4, DYT4 may be important. If it is combined and complicated with additional signs, then of course it does depend on the syndrome, but you may make sure that you do imaging with T2 star SWI, because brain iron accumulation and other things can be picked up by that. And a panel of blood tests is required for excluding hereditary disorders when you have combined dystonia. This includes routine blood biochemistry, copper ceruloplasmin, white cell enzymes, organic acid, amino acids, uric acid, occasionally an EEG, not necessary otherwise, and particularly important MRI with SWI or GRE imaging to pick up. Keep in mind that sometimes you may see abnormalities in GRE or SWI imaging, which may not be mineral, it may not be iron, although it looks like that, and it may be calcium. And therefore, in those cases, if there is a suspicion, you may need to do a CT scan. Just a couple of words about dystonia treatment, factors to be considered. Age of onset, distribution of the dystonia. Are there associated tremors or jerks? What is the functional disability or occupation? Does he really require treatment, he or she? Are there associated problems, depression, anxiety, which may need to be treated? So non-motor features are being increasingly recognized in dystonia, and this may be causing an issue with regard to your regular treatment, because the depression, etc., may lead to poorer outcomes even if you're treating them properly. So for focal dystonia, the main thing is botulinum toxin, physical therapy perhaps, while in generalized dystonia, anticholinergics, oral drug treatments may be the first option. If they are not sufficient, the oral treatments, then you go on to DBS with GPI stimulation, and sometimes patients with generalized dystonia may develop a dystonic storm, and this is a medical emergency. You may have to admit them to intensive care, and sometimes even DBS may be required. In those with focal dystonia where botulinum toxin doesn't work very well, and then in rare cases you may require DBS, and very, very rarely peripheral denervation in those with cervical dystonia. If you have combined dystonia, myoclonus dystonia, for example, zonisamide has been found to be useful, and some of these patients do very well with GPI stimulation. Dystonia Parkinsonism, symptomatic treatment might be levodopa. Dystonia with spasticity, symptomatic treatment is baclofen and other forms of treatment. Don't forget dopa-responsive dystonia, and don't forget Wilson's disease, both from the investigation point of view, but also from the treatment perspective. So in summary, the clinical spectrum of dystonia is expanding. It includes tremor, jerks, myoclonus, non-motor features. There have been a number of genetic advances which have led us to distinguish particular phenotypes. It is possible to use syndromic associations so that you can narrow down the differential diagnosis and to detect etiologies in complex cases. And there will be further advances. So we can't hide and say, well, I'm not going to follow this because there are too many genes and I don't know how to do this. So there will be further advances in the genetics, as it is not just in dystonia, but all other fields in movement disorders. There will also be identification of risk factors, both for genetic and environmental, to understand why the penetrance of dystonia is low. If we can understand that in the genetic forms, that will be very useful. There will be further advances in pathophysiology and better understanding of basic mechanisms, which will hopefully lead to potentially curative therapies, which we don't have at the moment. And apart from dopa-responsive dystonia and Wilson's, we are struggling to treat patients, and we do it mainly symptomatically. So thank you for your attention. And I'm going to stop this here, and I'll transfer you back to Shania.
Okay, thank you. I think, Kailash, we can, because sorry for that, I have forgotten to blend in the very first question. So I think I can blend it now, and then there will be 3 other questions from Kailash related to the medical content. So let us start. We have time, so that he knows what is your professional background. You can now vote. Okay, 15 seconds left. Okay, so I will show you the results.
Okay.
So the most of them are neurologists and neurology residents. Okay, should we go further with the next questions, Kailash?
Okay, so I've got a little, a very easy quiz for you, which you should find now very easy to do. So I will firstly have to share my screen. Yes, again, is that right?
Still not.
I'll share my screen.
Don't see your screen.
Hold on.
It should be in the upper toolbar. Yeah.
Can you?
Yeah.
Okay. So as I said, some easy test questions. Okay, so this is a 17-year-old girl. She's had this movement disorder for about 3 years. So I'll go on to the questions now.
Mm-hmm. And I will blend the okay, just let me check why is this not. Yeah. Now I will blend in that question. Yeah. Okay. 15 seconds left. Okay. So these are the results.
Okay. So we can see that the majority of you got it right. Some of you felt that she's primary craniocervical dystonia. I remember we chatted about this. So let me just close this one. The correct answer is none of the above. But I can see why some of you might have said it's craniocervical, because she seemed to have a gest. But the main thing was that she was actually too young to have craniocervical dystonia. And I'm just going to go back if I can. Why can't I go back?
You will have to share then your other presentation if you like to go back to the presentation.
You can see the answer you gave it or I gave it?
Yes, you gave the answer D. Yeah.
Yeah. So, but I can't seem to go forward or backward.
Yeah. Okay. Well, then I can share the files with your with the other questions.
No. I wanted to show them. Sorry. Yeah. Now I can.
Okay.
So I wanted to show you something. So you should have been suspicious because, and you see here, she's got a telangiectasia. Okay. So she's one of these patients who presented with ataxia telangiectasia, presenting mainly with dystonia. And the key was to suspect, because she had she was the wrong age and the wrong distribution for early onset dystonia, and hence we were very suspicious. We examined her very carefully, and we did the investigation subsequently and proved that she had the gene for ataxia telangiectasia. The reason I'm showing you this is to say that if it was the wrong distribution, wrong age, you have to be suspicious for a secondary cause. So here's the next one. Okay.
Okay, so this is the question. 30 seconds left. Already 55% of the people have responded. Okay. So now I will show you the results as you have voted.
Well done. So that's very good. So in fact, she does have blepharospasm, but she has in addition also got cervical dystonia, which you saw with the tilt of the head. She's a woman. She's around the age of 55, 60. So she has very classic primary segmental dystonia, and investigations here are unlikely to show any abnormality. This is not functional dystonia. So even though she has blephar, a lot of times this condition was thought to be functional in the past. This is an organic dystonia. So the answer is A, B, and C are correct. So again, I can't seem to move on. I'm not sure why this is. Okay, here we go. So this is an 18-year-old. He has onset of dystonia since the age of 13, and he can't speak and he can't swallow. And that's very brief. And you have to be like Sherlock Holmes. You also have to notice one more thing there. Okay.
Okay, I will show the next question. Now. Thirty seconds left. Okay, most of you have responded, so I will end the poll and show the results.
Well done. You are all become experts now. I'm very pleased. That's very good. So the reason is that he's obviously doesn't have isolated dystonia. So we talked about that he has a lot of bulbar involvement, and those of you who would have noticed he was using a towel or a cloth because he's got drooling, he can't swallow. You would definitely consider heterodegenerative causes, and brain imaging here would be very useful. You also notice he's in a wheelchair. So if he's in a wheelchair, there's no reason for a primary dystonia, even if it's quite marked dystonia, to be in a wheelchair. So obviously his balance isn't very good. That's why he's in a wheelchair. And that's why you are considering a secondary heterodegenerative cause. And one thing which is very useful in this situation is brain imaging. And again, this gentleman had on investigation brain iron accumulation disorder with PCAN gene positive. So all of you did very well. So it is the C and D are the correct answers, that you would consider heterodegenerative causes, and that the brain imaging would be very useful. So thank you very much for your attention, and it was a pleasure doing this with you.
Okay, Kailash, so I think now this was the Yes, you can stop sharing your screen, and this was the end of your questions. And we can show just right now the questions from the attendees, but I would like just to show a quick slide which was sent to us by the patient advocate from the disease group Dystonia, working for the European patient advocacy groups, Monica Benson. So their mission is to have the patient's voice heard, and their role in ERN-RND is to highlight the problems specific to those neurological illnesses that those affected have. Next milestones and needs in this disease group, according to Monica, is to create the dystonia patient journey, to have one expert center per disease group in each EU country, and promote the ERN-RND work by informing at meetings and congresses that there is this network and what it can do for the patients or for the clinicians. Okay, so we can go back to the questions and answer questions from the attendees, and maybe Kailash can address them. So there is one. Thank you for your lecture and your time. Could you touch upon the difference between segmental and multifocal dystonia in the new classification?
So segmental is contiguous body parts, while multifocal is multifocal. So let's say if you got neck and arm, that's segmental. You got face and neck, that's segmental. While multifocal would be face and arm without the neck being involved.
Okay. Then there is another question. What is the typical clinical course of DIY-T1 dystonia, particularly into late adulthood? Do individuals experience new or worsening of prior symptoms as they age?
It's a good question. Usually they worsen for the first few years and then more or less stabilize. So if somebody continues to worsen and worsen, then that's something odd, and you need to investigate that. So generally they will starts with the legs, worsens, affects the trunk maybe, and then they stabilize. Sometimes when they're anxious and so on, they may be worse, but it's not going to continue worsening and worsening and worsening.
Okay, thank you. Then there was one question we have received in the chat box regarding pathomechanisms. How do mitochondrial diseases fit into the triad calcium/neurodevelopment/dopaminergic system?
Very good question. I was just showing the main things which have come out from the new genes as to the pathomechanisms. But yes, mitochondrial disorders are certainly known to have dystonia quite prominently. So that's yet another mechanism which we should be aware of. So yes, that's a good question. Good point.
Mm-hmm. And there is another question. In DRD, how much of levodopa do you suggest to prescribe to patients in the center that don't have genetic testing available?
Well, I think it should be in all centers. It doesn't have to be in centers where genetic testing is not available. But in general, if you're treating DRD, now there is nobody who has set, there's no sort of evidence-based guideline. But generally speaking, in adults, I would give up to 300 milligrams of levodopa for up to 6 weeks to see if there's any response. While in children, you will have to, again, decide according to their body weight.
Okay, so we have two more questions, short questions. What is the treatment of bilateral blepharospasm with torticollis?
Botulinum toxin for both is the best option.
Okay. And the last question, can levodopa-induced dyskinesia occur in DRD?
Very good. Levodopa can help DRD immensely. some people might say 90% or so. Generally, it does not cause dyskinesia like you see in patients with juvenile Parkinson's. At the beginning, when you start levodopa, particularly in children, some of them may have a little bit of dyskinesia, but pronounced dyskinesia in somebody who's presenting to you with foot dystonia may indicate that you're dealing with juvenile Parkinson's with dystonia as a presenting feature. So you have to be cautious about that. And in that situation, a DAT scan would be very useful. In juvenile Parkinson's, the DAT scan would be abnormal. So this question can come in when somebody's got Parkin gene mutation, for example. They may present with foot dystonia, they may have diurnal fluctuation, but they will have a response to levodopa with a lot of dyskinesia, while the classic DRD generally remains dyskinesia free or not significant dyskinesia all their life.
Okay. Thank you. And one last question, and then we will finish the webinar. What is the initial drug treatment of writer's cramp?
So I think writing dystonia, most of the drug treatments are not particularly useful. In some people, you may use something like benzodiazepine to relax them, but botulinum toxin is very useful. And there have been people where thalamic lesions or thalamic stimulation has been used. So the choice of treatment, which is non-surgical, is botulinum toxin.
Mm-hmm. Okay, thank you. So we don't have any more questions.
I have to go now.
Thank you, everybody. Thank you, Kailash, for this webinar and for all your valuable input for our reference network. And thank you, everybody, and see you soon.
Bye-bye.
Bye-bye.
Thank you for your attention. Bye-bye.
Bye-bye.